So today we're going to be talking about hydrocephalus. So we're going to go over the pathology, MRI's involvement, we'll do a quick summary, and then a review at the end. We're going to start with the overview. So hydrocephalus is a neurological condition. It is described as dilatation of the ventricles of the brain. Hydrocephalus can cause major neurological issues due to the pressure on the brain tissue, which can result in loss of brain cells or things like a stroke. The main cause of hydrocephalus is an obstruction in the ventricular system or issues with cerebral spinal fluid absorption. In diagnosing hydrocephalus, first they'll go through a clinical diagnosis and maybe neurological testing. Some non-specific clinical presentations would be headaches, nausea, vomiting, blurred vision, poor balance, memory problems, urinary incontinence, and then in infants, we can notice an enlarged head circumference or bulging of the fontanelle. In diagnostic testing, in infancy, while the fontanelle is still open, we can do a cranial ultrasound, but once that closes, it is no longer an option. We then can do a CT, and for more specific testing, we can do an MRI. So in this image here, this is a normal brain MRI where the ventricles are normal sized, and on the right here, this is hydrocephaly with a dilation of the ventricles.
So for hydrocephalus, there is two main types of treatment, starting with the shunt placement, which is most commonly done. A shunt replacement directs excess CSF away from the ventricles to another part of the body. The first type of shunt placement is called a VP shunt placement, and its job is to drain the CSF from the brain, from the ventricles in the brain into the peritoneal cavity in the abdomen. The second type of shunt placement is called an LP shunt, and its job is to remove the CSF from the lower spine and redirect it to the abdomen. Another type of treatment done for hydrocephalus is called an ETV, or an endoscopic third ventriculostomy, and it is performed as an alternative to shunt placement in cases where CSF flow is blocked within the ventricular system. A surgeon would use a small endoscope to create an opening into the third ventricle, which establishes a new pathway for the CSF flow and reduces pressure. So the prognosis for hydrocephalus is vastly different depending on whether the person is able to get treatment. In infants and children, 50% of affected children who do not receive intervention die before they even reach the age of 3, and 80% of them may not survive into adulthood. So children who survive without treatment commonly experience permanent physical disabilities, developmental delays, brain injury, and lifelong cognitive impairments. In adults, idiopathic normal pressure hydrocephalus, or INPH, is an untreatable disease and it's associated with significant morbidity. A specific study reported that the 5-year mortality rate for their population was 87.5%. And hydrocephalus in adults can compress the brain tissue, which may in return affect the brainstem, which is the part of your body and brain that regulates heart rate, which can result in cardiac issues.
Ongoing follow-up is essential for patients with hydrocephalus to monitor the patient's condition and ensure proper treatment is being delivered. Clinical monitoring needs to be done to monitor signs of increased intracranial pressure, headaches, nausea, vomiting, visual disturbances, and cognitive or behavioral changes. These symptoms may indicate worsening hydrocephalus or shunt malfunction. Imaging follow-up is typically done with serial MRIs to assess ventricular size and progression or improvement. Comparing previous images with recent studies can help to identify subtle changes over time and help evaluate the effectiveness of treatment. The frequency of follow-up MRI depends on the patient's age, symptoms, underlying cause, and their overall condition. For patients with a shunt, regular follow-up is necessary. The shunt needs to be assessed for proper function with attention to signs of obstructions or over or under drainage. A programmable shunt needs to be assessed after MRI because the valve settings can be unintentionally altered from the magnetic field. Identifying problems with the shunt early allows for timely intervention or revision before it completely malfunctions, helping to prevent further complications and reducing the risk of increased intracranial pressure. MRI is the gold standard for diagnosing and managing hydrocephalus in children and adults. It provides excellent soft tissue contrast, clearly shows enlarged ventricles, helps to show the cause of hydrocephalus, and evaluates the flow of cerebrospinal fluid for any blockages. Another major advantage is that MRI does not use ionizing radiation and makes it ideal for follow-up imaging. Computed tomography is used in emergency situations because it is fast, widely available, and can detect ventricular enlargement and other findings. And as Kara said earlier, ultrasound is used in neonates with an open fontanelle, which provides an acoustic window to visualize the ventricles without exposing the infant to radiation.
And now we're going to talk about the MRI involvement. So hydrocephalus involves an abnormal increase in CSF, so MRI sequences that demonstrate fluid are especially important in this case. CSF has a long T1 recovery time and a long T2 decay time, and because of this, CSF appears dark on T1 weighted images and bright on T2 weighted images. T1 weighted images use a short TR and a short TE, while T2 weighted images use a long TR and a long TE. FLAIR is slightly different because it suppresses the normal CSF signal, making CSF dark while still allowing edema or abnormal fluid-related changes to appear bright. Now we're going to address the sequences commonly used for hydrocephalus. So T2-weighted imaging is one of the main sequences used because it shows CSF as bright. This makes it very useful for assessing the ventricles and identifying ventriculomegaly. This image here demonstrates the CSF as bright, which makes the enlarged ventricles easy to see, and this is why T2 imaging is very useful. The yellow arrow in image B points to a dark flow void within the cerebral aqueduct, which suggests moving CSF. FLAIR is useful because it suppresses the normal bright CSF signal, which helps abnormal findings around the ventricles stand out more clearly. In hydrocephalus, FLAIR can show periventricular hyperintensity, which may suggest interstitial edema from increased pressure or transependymal CSF flow. In these FLAIR images, the normal CSF signal is suppressed, so the CSF in the ventricles appears darker compared with the T2-weighted images that we just saw. This is helpful because abnormal signals around the ventricles become more noticeable. The white arrows in image B show periventricular hyperintensity, which appears bright around the ventricles. It is important not to confuse periventricular caps, which is seen in image C, with true periventricular hyperintensities, because caps can be a common finding near the frontal or occipital horns. 3D space is considered the most useful for hydrocephalus because it provides high-resolution imaging of the whole brain using small isotopic voxels. This means that the images can be reformatted in different planes without losing much detail. It is especially helpful for identifying the level of obstruction and assessing CSF pathways. In this image, the CSF appears bright, which helps outline the ventricles, the aqueduct, and also the fourth ventricle. The cerebral aqueduct looks morphologically normal, meaning that it does not appear narrowed or blocked structurally. The dark signal within the aqueduct is a prominent flow void, again, which represents CSF movement through the aqueduct. A 3D heavily T2-weighted sequence is helpful because CSF appears very bright while obstructions appear dark, and this makes the sequence useful for identifying small blockages within the CSF pathways. These heavily T2-weighted 3D images are useful because they make CSF very bright, which creates strong contrast between the CSF and any dark obstruction. Image A shows a normal midline sagittal appearance, while images B through F show hydrocephalus. Because the CSF pathways are so clearly outlined, this type of sequence can help identify where the obstruction is occurring. Phase contrast MRI is used to evaluate CSF flow rather than just anatomy. It can provide both qualitative and quantitative information about CSF movement, especially through the cerebral aqueduct. This is useful in cases such as aqueductal stenosis or when checking CSF flow after treatment. This axial phase contrast MRI image is different from the other images because it is focused on CSF flow rather than just anatomy. The region of interest is placed over the cerebral aqueduct, and this allows the scanner to assess the movement of CSF through that specific area. Phase contrast MRI can be helpful in hydrocephalus because it can show whether CSF is moving through the aqueduct and can also provide measurements of flow velocity or stroke volume. 3D T1-weighted imaging is helpful for evaluating brain anatomy and identifying structural causes of hydrocephalus. While T2-weighted sequences are better for showing CSF, T1-weighted images are useful for assessing masses, compression, and surrounding cranial structures. In this image, there is a left cerebellopontine angle mass. The coronal image shows the mass extending from the internal acoustic canal and compressing nearby structures. The sagittal image shows that the mass narrows the fourth ventricle and fourth ventricular outlet, which can block CSF drainage and lead to hydrocephalus. Contrast-enhanced MR cysternography is not used routinely because it is invasive and involves intrathecal gadolinium contrast. However, it can be useful in complex cases where the diagnosis is uncertain or when more detailed information about CSF pathways is needed. This figure compares different appearances of CSF spaces before and after contrast. In image B, the pre-contrast T1-weighted image shows CSF as darker. After intrathecal gadolinium contrast is given, the post-contrast T1-weighted images show contrast within the CSF spaces. This can help to demonstrate whether contrast is passing through normal CSF pathways or whether there is an obstruction.
Like any imaging, MRIs can be done in sagittal, axial, and coronal planes. The sagittal plane is useful for visualizing the corpus callosum, the third ventricle, and the cerebral aqueduct. As I mentioned before, an ETV is a type of treatment used for hydrocephalus, and in order to do it, it is very critical that there is clear visualization of the floor of the third ventricle in order to plan a potential surgical pathway. In the axial slice, the frontal and temporal horns are evaluated. Something known as the Evans index is measured, which compares the maximum width of the frontal horns of the lateral ventricles to the maximum internal diameter of the sclera. An increased Evans index helps assess the severity of hydrocephalus. Lastly, in the coronal slice, something known as the colossal angle is measured. The colossal angle is the angle between the lateral ventricles, and as it becomes narrower, anything less than 90 degrees, it helps distinguish any enlargement related to hydrocephalus versus enlargement caused by normal aging.
For equipment, we can use a spatial normalization software, which is used by aligning the acquired brain image of your patient with a standard brain image. It's used to identify anatomical differences. So in hydrocephaly, we can see the difference in the ventricle size. It is also used to ensure that shunts were placed accurately, as we can see down here in this image. Coils that will be used for a head MRI. For hydrocephaly, we're going to use a 3T MRI head coil, as you can see in this image here. We choose the 3T MRI head coil because it has better SNR, better spatial resolution, and will minimize artifacts. When assessing the entire shunt, we then also have to use a spine coil, as seen in this one here. And again, we choose the 3T one to improve spatial resolution. Some common artifacts that we see would be a motion artifact, which is due to movement in patients during the scan, resulting in blurring or ghosting. This is common because hydrocephaly is common in young patients, and they obviously can't sit still for the duration of the MRI. In this image here, you can tell this one here is obviously the motion corrupted image. It is a lot blurrier than this one here, which is not motion corrupted. Another common one is the partial volume artifact. It causes blurring of the ventricle margins, which will negatively impact accuracy of ventricular measurements. So when trying to follow up, we may not have proper measurements of the past ventricles versus the present. This is can be due to slice thickness. As you can see here, the 20 millimeter slice thickness is a lot more blurry versus the 2 millimeter, which has good detail. Another common one for patients with shunts is the susceptibility artifact, which is due to signal distortion in the area of the shunt, which will affect the appearance of surrounding brain tissue or just the absence. You won't be able to see it. So like in this image here, this patient had metal on their clothing, but it could be similar as the shunt, and you were just unable to see any of the anatomy in that area.
Before the MRI begins, the patient needs to be properly prepared to ensure safety and image quality. The patient is first asked to change into a hospital gown to prevent any metal in clothing from causing safety hazards and to prevent artifacts. All metallic objects such as jewelry, watches, hearing aids, hairpins, removable dental work, eyeglasses, body piercings, and magnetic false eyelashes must be removed. If contrast is being used, the patient is screened for any allergies, and for patients who experience claustrophobia or anxiety, a mild sedative may be prescribed if appropriate. To set up for the scan, an IV is inserted beforehand if contrast is being used. The patient will then lie on the MRI table with their head positioned inside a dedicated brain MRI coil, which is a helmet-like device that improves image quality. Straps and bolsters may be used to help keep the patient still, as movement would reduce image quality. A typical brain MRI for hydrocephalus takes approximately 30 to 60 minutes depending on the protocol being used. There are several important safety concerns when performing an MRI for patients with hydrocephalus. First, patients with programmable shunts should have their device checked after the scan, as the MR field can alter the valve settings or affect its function, causing it to provide inefficient treatment. Patients should also be screened for any additional implanted devices to ensure they are MRI compatible before entering the scanner to avoid any hazards such as heating, movement, or damage. Some patients may experience claustrophobia or anxiety while inside the MRI machine, so reassurance or sedation may be needed in some cases. And finally, lying supine during the scan can increase intracranial pressure, so patients should be monitored for worsening symptoms such as nausea and vomiting, especially if they already have increased intracranial pressure.
So, in summary, hydrocephalus is a neurological condition and is described as the dilations of the ventricles in the brain. Hydrocephalus increases the CSF, and T2 weighting images are helpful in visualization. T2 weighting, FLAIR, 3D space, 3D heavily T2 weighted, as well as PCMRI and 3D T1 weighted images are also helpful in many different scenarios. Common artifacts include motion, partial volume, and susceptibility. And lastly, safety concerns include programmable shunt devices, anxiety, and increased intracranial pressure.
Okay, now we're going to do a quick quiz. So pause and try to answer the question yourself. So first question is true or false? All patients can be diagnosed through a cranial ultrasound for hydrocephaly. This is false. Only infants with an open fontanelle are able to be diagnosed through a cranial ultrasound. Question 2, what artifact is demonstrated in this image below? And the answer is susceptibility artifact.
Question 3, which of the following is not a safety concern during MRI in a patient with hydrocephalus? And the answer is C. MRI increases CSF production, making hydrocephalus worse. So MRI does not increase CSF production.
And this is the last question. So which of the following is false about FLAIR? And the answer is A, evaluate CSF flow. This is not FLAIR, but this is a characteristic of PCMRI.